Hello and welcome to the last of our 3 podcasts from the webinar program on highlights in lung cancer from the ASCO 2011 annual meeting in Chicago, Illinois. I'm Dr. Jack West, medical oncologist in Seattle and also the president and CEO of GRACE, the global resource for advancing cancer education. And I was joined during that live program, co-sponsored by the Longevity Foundation, by Drs. Mary Pinder-Schenk, assistant professor in medical oncology at the H. Lee Moffitt Cancer Center in Tampa, Florida, and Dr. Nasser Hanna, associate professor in medical oncology at the Indiana University Cancer Center in Indianapolis, Indiana. Following their presentations, we did a question and answer session in which members of the webinar's live audience asked their own questions, and there were also some that I posed. Here's that session. Mary, you covered small cell and non-small cell lung cancer. There are patients who have a combination of small cell lung cancer and non-small cell lung cancer elements. The question is, how common is this and how does the lung cancer community approach this situation?
Well, it's not very common. Small cell is uncommon in itself compared to non-small cell, but it does happen. And I actually have probably 3 or 4 patients in my practice right now who had gone to surgery for what was presumed to be a lung cancer, an early stage lung cancer. And once the tumor was completely removed, it showed both small cell and non-small cell elements. And typically our approach is to treat that cancer more like small cell lung cancer. So obviously surgery isn't something we usually do for small cell, but sometimes we're surprised. Although once I see a small cell, I will usually use chemotherapies directed at the small cell component, although there is some cross activity with those drugs. So I would say most of the time we treat it more like small cell if there's a mixed tumor.
Nasser, any added comments about that?
I agree with Mary. It occurs between 5 and 10% of the time in surgical series. There was an intergroup trial looking at the role of surgery in small cell lung cancer a number of years ago, and patients received chemoradiation and then were randomized to surgery or not. And about 10% of the patients who had their small cells resected actually had a component of non-small cell in the surgical specimen. But I agree with Mary. You treat the more aggressive component, which is almost always the small cell component. If you have an early stage tumor that you resect, we offer an adjuvant chemotherapy. If it's locally advanced disease, we treat it mostly as small cell.
Thank you. Another question came in about the selection of the choice of adjuvant chemotherapy. Mary, you made the point, which is borne out by the data, that in the United States, there's plenty of use of other regimens than cisplatin and navalbine or vinorelbine, and certainly a lot more than some of the older regimens that have been proven with the data. With a combination like cisplatin and pemetrexed or Alimta, the question is there any disincentive to using this as an adjuvant therapy because of a concern for limiting your options in the metastatic and more relapsed refractory setting? Maybe I could start with you, Nasser, and then get Mary's thoughts here.
No, I don't think so. You want to use your best drugs. You want to give your patient the best chance for cure. I think the risk of doing trials that Mary had described, looking at cisplatin and pemetrexed from several years ago, is that because it was a newer regimen and less was known about the drug, we didn't recognize that patients with squamous cell cancer did not benefit from pemetrexed. So unfortunately on that trial, a number of patients were treated with something that I would consider substandard. And you have enough information about the drug, and we do with pemetrexed now, and we certainly do with older drugs like vinorelbine and docetaxel and gemcitabine, then I'm perfectly comfortable with applying that logic in the adjuvant setting.
And Mary, what are your thoughts here about both the acceptability of interchanging one for another and then concerns about limiting your options for relapse?
I really would agree with Nasser that in the adjuvant setting, my primary goal is to cure more patients, and so I'm more concerned with the here and now than the eventual relapse of the patient. And I think we really don't know if the patient got it in the adjuvant setting, would they truly not respond if they did relapse? We saw a little bit with Tarceva that you may respond and then respond again. So I think I'd be much more concerned with trying to maximize benefit in the adjuvant setting.
Great. Another question came up that was asking, is there any more information about the trial with adjuvant erlotinib, Tarceva, for a couple of years versus placebo? And I can actually just feel that that's the RADIANT trial, and I'll mention that I did speak with the primary investigator for that, who is Dr. Karen Kelly, now at University of California, Davis. That trial has accrued its full enrollment of nearly 1,000 patients, but I think it'll be another couple of years before that is enrolled. The question I would ask both of you is, in the meantime, we've seen some provocative and troubling data from the Canadian trial BR19 that gefitinib Iressa could have a detrimental effect not only in a broad population, unselected, but even in patients with an EGFR mutation. And yet there are data that come from Memorial Sloan Kettering, retrospective and not a controlled trial, that suggests that patients with an activating EGFR mutation may benefit from an EGFR tyrosine kinase inhibitor. So first, the question of, do you test for EGFR mutation or other molecular markers, and do you use it particularly in patients with an EGFR mutation? Mary, why don't I start with you here?
Well, in answer to the question, do I test? I definitely am testing in patients who we discover are stage 3 lung cancer after the resected. So in people in whom I think there's a very high risk of recurrence, I'm testing to have that information available for the future if it's needed. I am not giving adjuvant erlotinib right now because I just don't think that we have enough data. And given the concerns with the BR19 trial, I don't feel comfortable doing it for patients right now.
Nasser, what are your thoughts?
No, I agree. I would definitely not give a patient adjuvant or erlotinib off of a clinical trial. The Memorial data was very compelling to me. Essentially, they had looked at their patients, a series of 100 or so patients who had EGFR mutations who were treated without Tarceva in the adjuvant setting, and then they adopted a policy to treat those patients with Tarceva if they had an EGFR mutation. And so it was consecutive patients, and they compared about 100 consecutive patients with and 100 consecutive patients without, and the disease-free survival was substantially better for the patients who were treated with Tarceva, and that was very compelling. But you referenced the intergroup trial that was stopped early looking at adjuvant Iressa. There was a worse survival for those patients. They looked at the subset of patients with EGFR mutations, which was a smaller subset. And even in that subset of patients, there seemed to be a disadvantage to giving patients Iressa. I think we need to await the results of the RADIANT trial, but there is enough there to warrant, I think, not routinely giving patients Tarceva in the adjuvant setting. I don't check EGFR status on any patients who don't have metastatic disease. One of the reasons why I don't check it on the patients who have it surgically resected, and Mary and Jackie both know this, is that the EGFR mutation status can differ between a metastatic tumor and a primary tumor. And if a patient is EGFR wild type in their primary tumor and they develop metastatic disease, it doesn't necessarily mean that they have EGFR wild type metastatic disease.
And the other thing is that over time, if somebody has surgery in 2011 and develops metastatic recurrent disease in 2013, the biology may be different. I would certainly be concerned about using data from a remote surgery to make presumptions about how to treat someone at a recurrence years later. In the adjuvant setting, and Mary, you're at a place that has really pioneered a lot of this work on tailoring the chemotherapy choice based on marker studies like ERCC1 and RRM1. You highlighted some of the clinical trials going on. Do you obtain these studies and do you use those results to guide your treatment selection outside of a protocol setting in the post-operative setting? Mary and then Nasser.
Yeah, it is kind of strange that although we've pioneered the work on ERCC1 and RRM1 here, I've actually polled all my colleagues here to see if any of them are using it off protocol for adjuvant treatment, and no one is that I know of, and I certainly don't, because I think we are still awaiting the data, number one, from the metastatic trial, where we prospectively used ERCC1 and RRM1 to tailor therapy, but we're also awaiting prospective data from a number of adjuvant trials. So we have the SWOG 0720 trial open here, which uses ERCC1 and RRM1 to either select chemotherapy or observation for patients with stage 1 lung cancers. And I have put a number of patients on that clinical trial, but outside of a clinical trial, I'm not checking any of the other markers.
Nasser, how do you approach this situation?
Yeah, I don't either, and it's very appropriate for a clinical trial, but there are other markers. The NCI Canada study that looked at adjuvant cisplatin and vinorelbine had a planned analysis of looking at the KRAS mutation positive, P53 positive patient population. And while the study poll was positive, showing adjuvant cisplatin and vinorelbine improved the number of cures, when they looked at the planned subset of those with KRAS mutations, for instance, there was no difference in survival between the two arms. And so the question is, if you knew a patient had a KRAS mutation, would you not give them adjuvant chemotherapy based upon that pretty strong data? For me, the answer is no, I would still give them adjuvant chemotherapy. It'd be hard to tell somebody who has stage 3 disease for whom we know adjuvant chemotherapy has the biggest impact, that based upon no prospective randomized trial, that I'm not going to give them adjuvant chemotherapy. I think in a tough call situation where maybe the patient is stage 1B, they're maybe older, say they're 78, they have a few comorbidities, you probably could give them chemo, but you're nervous about it. They're not terribly anxious for chemo. You get a little bit more information and you find out that they have high levels of expression of ERCC1, or you find out they're KRAS mutation positive. Those may be variables that help decide, but for most patients, I don't use those markers.
Let's turn to metastatic non-small cell lung cancer. There was a common theme, Nasser, that you alluded to. Everything seems to be increasingly molecularly guided. We have the ALK data, I completely agree, very exciting, and a lot was also about MET and now EGFR, of course. So, and I believe you spoke at ASCO in giving some commentary about what are the implications for collecting molecular marker data prospectively in the metastatic setting. And so can you please give your thoughts, impression of what the data support for how aggressively to chase down getting tissue if necessary and doing molecular testing, and for what in terms of making this a standard? And is it for all histologies or for minimal or never smoking adenos?
Well, that's a great question. So ASCO has provided some guidelines on this recently, and it is now the standard of care to do EGFR mutation testing on all patients with metastatic adenocarcinoma. So I'll say that again. That is now the standard of care. The vast majority of patients with EGFR mutations are going to be either never, light, or remote smokers, but not entirely. In fact, in the initial report by Dr. Lynch and colleagues, the patient who had the best and longest response to afatinib was actually a patient who did not have an EGFR mutation, and that patient was a heavy smoker. So it's not exclusively this group, but it's overwhelmingly this group. I think if the ALK data is validated, and I think we all feel very confident, and we've seen a lot of things look promising and fall by the wayside, I think the lung cancer community would be shocked if this data is not validated. So we're all anticipating that ALK will be a validated target and that crizotinib and other ALK inhibitors will be used in a standard way very, very soon. I think when that happens, and I expect that to happen this year, it'll be standard of care to assess all adenocarcinoma patients with metastatic disease for both EGFR mutations and ALK gene rearrangements. Has to be noted that 28% of the patients with adenocarcinoma who had an ALK gene rearrangement were former smokers, so that definitely shouldn't discriminate. The question is, what do we do with patients who have squamous cell cancer? We know that occasionally patients with squamous cell cancer are found to have EGFR mutations, and occasionally they're found to have ALK gene rearrangements, but it's very, very uncommon. And so my take on this is you should do EGFR and ALK testing on every patient you have. If you don't have adequate tissue, my view is that you should rebiopsy every patient. If it's difficult to rebiopsy for whatever reason, it's an incredibly challenging disease and an incredibly challenging patient population, If it's going to be difficult, if it's going to be risky, it's going to be hard on the patient, then I think you have to use some of those clinical characteristics to make your best judgment. If it's going to be very hard and the patient's a heavy smoker with clear squamous cell cancer, I think you can safely say the likelihood of having this is so low, it's probably not worth the risk. But if I have a patient who maybe quit smoking 5 or 6 years ago, and they have an adeno or an adenosquame or a not otherwise specified, which is found a lot of times, sort of a poorly differentiated non-small cell, I really think that we should do everything we can to get tissue and to do this testing. And what I think we're going to be seeing, hopefully 3, 4, and 5 years from now, is the menu is going to be much broader than that. We know in patients with metastatic melanoma, it's standard of care now to assess patients for BRAF mutations. I suspect that we're going to end in colorectal cancer. If you're going to treat somebody with a EGFR antibody, it's standard of care to check patients with KRAS mutations. It's going to be important for local pathology labs, for community practices, for all university hospitals to have pathology departments that have the capacity to do this wide screening.
Let me ask you a little different situations between ALK and EGFR, and that is that with ALK, your only opportunity to get crizotinib right now is if you have an ALK rearrangement. With EGFR mutation or lack thereof, the real question is whether this is advisable to give as a first-line therapy or as a second or third-line therapy. And as you showed in the results from the URTAC trial, the survival differences were not really there, presumably because of crossover. So then the question is, if the standard treatment is going to be everyone gets a chance anyway, and the real question is whether you get that bigger benefit now or a few months from now, how much does the molecular testing become a mandate, at least for an agent that is available to everybody, and it's just a question of timing?
Yeah, it's a great question, and so our markers are not perfect. It's true that women with breast cancer who have very modest ER positivity occasionally respond to tamoxifen. But if you've got 5% cells staining for ER positivity, I would venture to say very few physicians would treat you with tamoxifen. Your response rate is not 0, it's low, it's probably 3 or 4%. The same is true for patients who have EGFR wild type. The likelihood of response is very, very low. It's not 0, but it's very, very low. And I think you want to give your patients preferentially the drug that's most likely to be active for the longest period of time. So if I knew a patient had an EGFR mutation, I would definitely offer them erlotinib first line. Some of these patients respond for a very long period of time. Sometimes it's not months, but it can be years, and I think we all have patients in our practice who respond for many years. I also think it's important for the lung cancer community to get into a sort of a mind shift, and that is that it's true that a drug like erlotinib is not active only in the EGFR mutation population. But to be frank, erlotinib is a fantastic drug if you have an EGFR mutation. It's a very mediocre drug if you don't have an EGFR mutation. And so we're probably going to be encountering a whole menu of drugs in the next 3 or 4 years, and we're going to have many options. You're going to preferentially choose a drug based upon the molecular profile.
Mary, what's your approach in this situation, both personally and if your institution now has a policy for who to do so-called reflex testing on for molecular markers?
Well, we are participating in the Lung Cancer Mutation Consortium trial, so we have been putting quite a few patients on that trial. If the patient isn't a candidate for that trial, and really the biggest barrier to patients being a candidate to the trial is the amount of tissue that's required. It's a fairly large amount of tissue, more than we would need just to test for EGFR, for instance. So if the patient isn't a candidate, we're not reflex testing, but basically recommending that all of our physicians test all patients with adenocarcinomas for EGFR and ALK. We do have the crizotinib trial open here, so a lot of the ALK-positive patients are headed towards that trial. We just submitted to our institutional review board a trial of a BRAF inhibitor for patients with BRAF-positive lung cancer. So kind of in preparation for that, I'm starting to test patients for BRAF. And we have a couple of other trials coming down the pike. One of them is going to be for KRAS positive patients. So I'm now also starting to test patients for KRAS. If they're on the lung cancer mutation trial, then they get all that testing done. And if not, I'm testing for all four of those things in my adenocarcinoma patients because they either have off-protocol or on-protocol options.
Great. Several people had questions about the mutual exclusivity of the various mutations. Practically speaking, if you have a patient who has been tested previously for an EGFR mutation and has it, but then develops acquired resistance, would you test for an ALK rearrangement later on, or would you do any more molecular testing at the time of acquired resistance? And are there other clinically relevant markers at this point, especially when you showed in the Memorial Sloan Kettering experience by Jen Jingy and colleagues that T790M didn't actually seem to discriminate effectiveness?
In a perfect world, in a perfect setting, you reassess the molecular profile of the disease every time the patient progresses because you assume that the resistant cells that you're dealing with now have a different molecular profile than the sensitive cells that you were positively treating. This is hard to do. Patients who have palpable tumors, it's not hard to do, but patients with lung cancer who require bronchoscopies or liver biopsies, this is hard to do. If we were to look into the crystal ball 5 years from now, what I hope, and I'm cautiously optimistic about this, I hope we can do this all with serum testing to isolate circulating tumor cells in the blood and to do molecular testing on circulating tumor cells. The group at Harvard and other groups have been working on this. Actually, at Purdue University, they've been working on this as well. Dr. Sequist at Harvard was able to report out, this was about 1.5 years ago, that they were able to identify the EGFR mutations in circulating cancer cells just as well, and actually even a little bit better than they were from direct tumor biopsies themselves. So I think, and I hope, that's going to be the future where we're actually assessing the disease in a sequential manner from peripheral circulating cells. For now, my preference is to rebiopsy, but I do recognize that that is a very hard thing to do. And unfortunately, our patients are oftentimes older, they have comorbidities, and that adds to the challenge of doing that.
And a couple of follow-up questions after the acquired resistance trial, and that is, what was the side effect profile for that combination of cetuximab and afatinib, and is there any real concern about the tolerability of it?
That is a concern, and the main side effects of cetuximab are infusion-related reactions and an acneiform-like rash. It doesn't cause nearly as much diarrhea as the tyrosine kinase inhibitors. The irreversible tyrosine kinase inhibitors have the same profile as the irreversible tyrosine kinase inhibitors, and that's primarily mucositis, diarrhea, the acneiform rash. And I would have to review, I don't know off the top of my head, perhaps you or Mary do, what the combination side effect profile looked like. I presume it was that, but do you know off the top of your head?
Well, my understanding, and this is more from talking to people who have worked with similar combinations, but not that exact one, were that rash can be a big issue. And it seemed to not be prohibitive in that subset, but we do sometimes see that there are differences in the outcomes between a 1 or 2 institution study and then when it's broadened to a more multi-center experience. So I don't know, Mary, if you have worked with these drugs directly or similar combinations, but the concern was about the rash, the dermatologic toxicity really escalating to a point of it making the challenge that we sometimes face with just Tarceva seem like a walk in the park.
Yeah, we had a trial of cetuximab and radiotherapy, and even without the erlotinib, I found the cetuximab rash could be a real challenge to manage. The other thing that's really interesting is that cetuximab has this regional variation in fusion reactions. So in Seattle, I rarely heard much about infusion reactions. Here in Florida, where a lot of our patients come from northern Florida and Georgia, we actually do see a fair number of severe infusion reactions with cetuximab, and I've had a few patients have it, and it's been difficult.
Right, and I believe that the thought on that is that it's presumed to be related to some cross-reaction with some allergen in the area of Georgia and the Carolinas and a little in Tennessee too. But in the southeast U.S., the rates of severe reactions can be in the 20 to 25% range, and it's a very fearsome drug, frankly, in that community.
Absolutely. We had to pull patients off the protocol once they had a reaction.
So I think those are all things to wonder about as this broadens. And I did talk with Dr. Janjigian about future plans, and certainly there is a lot of enthusiasm about moving this forward, and the company Boehringer Ingelheim is planning to do a larger phase 3 trial, if not several other trial experiences that are being developed to broaden in the next few months or around the end of this year. So we'll see this tested in a larger setting beyond the handful of centers where it is now. Another question, in fact, a couple of people have asked about the significance of the lack of any real difference between the outcomes in the T790M positive patients and those not, in terms of how does it jibe with the preclinical expectations, and what does this mean moving forward? Nasser, do you have any thoughts on that?
Well, it calls in, the preclinical data suggests that the antibody and the irreversible TKI would have a more positive effect, but we don't know if that preclinical data always translates to the clinical. It may very well be that the irreversible inhibitor on its own was doing most of the work. We're confident that the antibody is not likely doing it because we have a pretty good range of experience with patients who've been treated with antibody alone with these gene profiles. So I don't know. There may be something to it. It may be the combination. It may simply be the irreversible inhibitor.
And then a last question I'll ask both of you. It's not directly related to the ASCO presentations, but the NLST, the National Lung Cancer Screening Trial, was newsworthy, in fact, one of the bigger news features last year, and arguably practice-changing, that showed an improvement in survival. I understand that that will be published very shortly, perhaps next week. So my question is, and I'll start with Mary, what do you see as the impact of that trial and the overall view of screening for lung cancer in 2011 now?
I think it really is part of a paradigm shift in how we treat lung cancer. And I think all the presentations, especially those that Nasser talked about tonight, we're really starting to see lung cancer with less of a fatalistic approach, and I think that's a good thing. So we're seeing it in stage 4 disease. We're testing patients. We're doing biopsies. We're being more aggressive about putting patients on clinical trials. And I think now we're seeing it in the screening setting. So we have an intervention that potentially could save a lot of lives if the final report bears out the press release. And I think that many institutions around the country, my own included, are already gearing up to really get aggressive about screening for lung cancer and figure out which patients we're going to select, how we're going to offer testing, how often. And then I think the final piece of the puzzle, though, is going to be, will insurance companies and Medicare pay for lung cancer screening? I think we can all agree that healthcare costs would certainly go down if we catch more lung cancers at stage 1 compared to stage 4. But I think proving that and getting payers to recognize it may be a little bit challenging.
Nasser, what are your thoughts about whether the weight of the evidence is sufficient to change not only what practice should be, what's paid for, and what's considered a standard of care?
Yes, I think it should be. The impact on mortality is greater than that of adjuvant chemotherapy. It's significantly greater than that of adjuvant chemotherapy. So the cautionary note here is that hospitals and hospital systems need to have in place plans on how to assess these CT scans, because lots of patients have abnormalities found, and you have to have a system in place to know what to do with that information. who to biopsy, who to get a PET scan, who to observe, who to go to surgery, and who should and who shouldn't be getting these CT scans. So there has to be a lot of education, a consent to getting these, the implication of a false positive, follow-up. And the other thing that I think is such a major part of a screening program is the availability to get people to quit smoking. When they go for a screening CT scan, it is a fabulous opportunity to have smoking cessation, counseling, opportunities, engagement. At that moment, the patient is motivated, and that's very important. And that's important for our nation's health in general, because not only does smoking cause lung cancer, but it causes about 30% of all cardiovascular deaths. It causes 90% of all patients who die of COPD and strokes and vascular disease and about 10 other cancers. So I would utilize the screening programs that hospitals will likely have set up as an opportunity to help people quit smoking.
It's interesting. You bring up a few points, and one is it is important to bear in mind who was the subject population in the screening studies, because the probability of having the problem in question, in this case lung cancer, matters. And so they concentrated on somewhat older but not very elderly people with a smoking history. And at this point, the data don't say anything about doing screening on never smokers in their 40s or anything. And so we would need to bear that in mind, that at least what we have for the data supports doing it in people with a significant smoking history and, in the 55 to 75 range, although it would be broadened potentially. And then the other issue being, amazingly, I've heard primary care doctors talking with their patients after getting a chest CT in, sometimes the response being, well, I'm clear, so I feel now that I'm enabled to continue smoking now that I've cleared that hurdle. So definitely would hope to make the most of a teachable moment and not to absolve people from that.
And I think, Jack, one other major finding of that study is that 1 out of 4 people who had a screening CT had an abnormality found. Now, in Indiana, where histoplasmosis is far more prevalent, I think our numbers will be most closely aligned with what was seen in the Mayo Lung Project, where they looked at 1,500 patients screened with CT scans, and 50% of those patients had an abnormality found. And so if you're going to screen a patient, particularly in Indiana, but really anywhere, you have to prepare them that there's a pretty decent chance you're going to find something, and there's a pretty decent chance that that something is not going to be anything. And that's what I mean by hospitals and hospital systems have to be prepared to deal with the consequences of finding things on X-rays.
Right, and that includes the anxiety and the potential need to biopsy and even do limited surgeries. You have to buy into going down that road, just like we've had to do with screening for breast and prostate and other situations where you have to buy into the concept of facing down wherever this leads you if you're going to open that Pandora's box, I guess. But clearly, the data are extremely compelling. I don't think anybody in lung cancer at this point, as a leader in the field, feels that the screening issue can't effectively save lives. I think that really shows it absolutely can, along with the LCAP data, as controversial as they have been, still supporting that same concept.
I think it's also a real opportunity if we do start screening and we do research to try to figure out, either through blood testing, molecular testing, or through imaging characteristics, which abnormalities are most likely to be cancer. And maybe we'll be able to refine our protocols with further research.
Right. Well, there's a lot of, it's not just screening, but we're going to be undergoing a sea change as not just the medical oncologist, but we need to work with all of the other disciplines we work with, especially the surgeons and interventional radiologists and pulmonologists, to highlight the need to get more tissue, because it's going to be very unfortunate if people come to us with fine needle aspirates and very limited cytology specimens, and more we need to send people back for another biopsy because so much is going to be based on both histology and molecularly directed therapy. So we're going to have to retrain a lot of the people who we work with about the changes in the field. So this brings us to the close, and I wanted to give my profound thanks to Dr. Pinder-Schenk and Dr. Hanna for spending their time and providing such great insights today. We hope this program was helpful and informative. Thanks for listening, and thanks to Longevity Foundation for partnering with Grace in this series.